Welcome to Black Health Matters. I'm your host, Darryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
Those those of you who are busy doing those board games, it is a benefit to the mind, so don't stop. Any comments on that?
Yeah, I do Sudoku every day.
I'm going to play Pacino tonight.
I'm using chess currently while I'm in the hospital because I've had some brain injuries.
Okay. The other article, we've talked a lot about sugar substitutes, and this article really talks about the science of sugar substitutes and recognizes that if you got diabetes, that sugar substitutes are better than sugar. It also rates the sugar substitutes in terms of which is the least likely to be damaging and which is the most likely. And they they come up with aspartame as being the most commonly used in the diet sodas, and they say that those people who use diet sodas are more likely to get type 2 diabetes than those people who don't use diet sodas, and they're more likely to be overweight as well. But they say aspartame, number one, sucralose, and number two, saccharin and stevia, three, and they recognize that sugar substitutes are certainly better than sugar if you are a diabetic. But they just want you to understand that it's not a win-win with sugar substitutes. So if you're not a diabetic, it's not you shouldn't load up on sugar substitutes. Uh, it's an interesting article. Those of you who take the Washington Post on Mondays, that health section is recommended to read. Any comments about that?
Dr. Callender, what about honey is a substitute?
They don't mention that they haven't done any studies on honey.
Okay.
Uh, okay, well, I guess we can go to the articles, John Buchanan. This is an interesting article because we don't talk much about this particular type of stem cell transplantation because in the future, xenotransplantations and stem cell transplantations are where the future lies. So we're having more interest in xenotransplantation, that is transplantation between organs from other species like the pig, which is the commonest now. There was actually just uh, in August, there was a lung transplant in China, first of its kind from a pig. But this ghost transplant, they call it, is a situation in which they eliminate all of the organ except for the scaffold or the connective tissue that holds everything together. And they then implant human cells on the scaffold. And this then, if it can be used, will uh, not be associated with the hyperacute rejection that occurs. Now, this is experimental and has been used only sparingly in one or two cases, unlike the xenotransplant, which has been used and is going to have extensive studies. But this situation where you eliminate all of the organ except the connective tissue scaffold, and then put human cells in the scaffold to make the organ utilizable for a human, whether it's from a pig or any other animal, is something that is likely to take place in the near future. This is something that is not a new concept, but it's a concept that has not yet been proven to work. So so when they talk about ghost transplant, that's what they're talking about, where you take out all but the connective tissue of the organ and then put human cells on the organ, also making sure that it's not thrombogenic because uh, uh, if it clots, it's of no value. So, so this is a technique that is being used with livers, but it eventually will be used on hearts as well. Uh, and Time will tell whether it will eventually lead to uh, successful human transplantation. Any questions about this concept, which is relatively new? I think about 5 to 10 years ago, first started talking about this with hearts and lungs, but it's not advanced yet to the point where uh, we're actually doing any transplants. But it has the possibility that down the road, maybe 5 to 10 years hence, we may be able to successfully uh, use xeno organs and pig organs and take out the pig structure and put the human cells in it and have that as a successfully grown organ transplant. Is it a new concept? Any questions about it? Because I'm sure it's mysterious to you, but it's one of the things that as we talk about xenotransplants, we tend not to talk so much about stem cell transplantation, but stem cell transplantation is the future as well. And the latest successful venture in stem cell transplantation is that we no longer need to worry about using embryos and fetuses. We can now transform cells into stem cells, which can be used hopefully down the road. We'll have heart cells that can be used to overcome the uh, heart attack and heart failure by uh, injecting heart cells into the heart and having them being repaired. And this then is where the future lies in terms of successful stem cell transplantation and successful uh, xenotransplantation, as well as the uh, recognizing that, for example, if we had islet cells for a transplant, we would eliminate diabetes, heart failure treatment by stem cells from the heart, and so on. Any comments or questions about the what I'm talking about in transplantation for the future?
I had one question, Dr. Callender. Good morning, everybody. John Tatum here. Um, would this qualify for transfers,
Multi what?
organ transfers?
Right now doesn't qualify for anything but study. Down the road, it will be a potential for liver and kidney
Thank you.
transplantation. Any other comments or questions about this technique, which may be confusing to many, but it may well augur well for the future for transplantation 10 years from now?
Yeah, my question is the stem cells, since they don't come from embryos, where do they come from? The patient or another
Yeah,
donor?
it can come from any cells now. We have the capacity to transform squamous cells into stem cells. that can become capable of transforming into from skin into uh, other cell structures that could be myocardial tissues, could be muscle myoblasts, could be heart, could be uh, whatever. Nowadays, we have a process by which uh, adult squamous cells can be transformed into stem cells and used for the purpose of growing tissues.
And what are squamous cells?
Say again?
What are the squamous cells?
Oh, squint. Okay, skin. For example, we're talking
Oh,
about
skin.
skin. That's an example of squamous cells. So that's the first successful transformation that has occurred in which by using enzymes, they were able to transform skin squamous cells into stem cells. That's the most recent technology that gives us uh, promise for the future that we already have the gene uh, altering technology, CRISPR-Cas9, but now we also have the possibility of stem cells being transformed and used to have tissue transplants, such as eyelids, corneal transplants, and others. I would imagine in the next 5 years that uh, stem cell transplantation will advance to the point where xenotransplantation is today. Any other comments or questions as we will follow this as time goes on? But this is the ghost. When you say ghost transplantation, this is what they're talking about, where you take out all of the structures except the connective tissue and then repopulate the organ with humanized cells that would not be subject to rejection. Okay, if there are no other comments or questions, we'll go to the next article. Although this is labeled as being what treatments really work, they don't really answer that question. Bronchitis is a condition that involves inflammation of the bronchial tissue and it makes it difficult to breathe and causes wheezing. And as a consequence, because it's an inflammation and it may be acute, subacute, or even chronic, it sometimes is treatable by antibiotics, but sometimes it isn't. And sometimes it's caused by virus, sometimes it's caused by bacteria, sometimes it's caused by fungus. But for the most part, uh, successful treatment of the subacute and chronic bronchitis is problematic. And the main treatments that they recommend still wind up. Uh, Many people are on for chronic bronchitis are on inhaled steroids, which can be of some benefit, and they're on drugs that allow the sputum that occurs as a consequence of bronchitis to be expelled by coughing. Uh, but there really isn't a magic bullet for bronchitis. And it's something that once you have, it's hard to get rid of. And there are many kinds of treatments, bacteria, virus treatments, and fungal treatment, and steroids and such. But to claim that there's a bona fide treatment that always works for bronchitis is a little more than a notion. So this article really fails in identifying what treatments really work, although there's a a quandary of treatments that may be of benefit. But inhalers and people who have bronchitis and wheeze can use inhalers that are effective in dilating the bronchial tubes and allowing you to overcome the problems associated with the bronchial asthma and the bronchitis. Any questions or comments? I don't see any hands raised. Are there any?
Janice has a question.
Yes. Dr. Callender?
Yes.
Yes. Is that any way connected to sarcoidosis?
No. Sarcoidosis is a specific autoimmune disease that is separate disease. It requires separate treatment. That's a condition that's found in particularly in Black women, but is usually treatable by steroids.
Yes. Mhm.
Yes. Good morning, Dr. Callum. This is Elizabeth Dorch.
Welcome.
Hi. I just wanted to quickly mention that I've invited the Washington Senior Wellness Center, some of my friends and associates that I do wellness with. So we're in the multipurpose room online watching you.
Oh, thank you.
You're now on our calendar.
Oh, thank you. Good to see you.
So tell Dr. Callender hello. Hello, Dr. Callender.
Hello.
Hello.
Welcome to our group meeting. We're glad to have you. Okay.
Calendar's on the calendar.
Elizabeth,
Yes, dear.
this is Sarita. I'm on Zoom.
Oh, Miss Sue. Oh, thank you, Miss Sue. You are so welcome. Thank you for joining us. You're gonna love Dr. Callender discussions. I'm not gonna go into
Yes, so far, I'm being well educated.
thank
Well, thanks for having such a nice audience to be with us today. We deeply appreciate it. Okay. All right. Any other comments or questions?
I wanted to ask Elizabeth approximate number of people that she's there with. Dr. Elizabeth?
John. You know, I'm trying to work the technology here.
Okay, well, just tell me later. Tell me later.
Okay.
All right.
Don't forget I'm on Zoom, Elizabeth.
Okay, Miss Sue. Thank you.
Janice, do you have any other questions?
No, I don't.
Okay.
Thank you.
All right. This article is about myths about influenza vaccination. As you know, there's a lot of anti-vaccination people, and there's a lot of myths about vaccine, the influenza vaccine, which of course is the commonest vaccine. And there are many people who think that you get the flu from the vaccine. And that's one of the myths that they also, the myth about if you're allergic to eggs, you can't take the vaccine. And actually, that is not the case. But so there are many people who have allergies to eggs actually are able to take the vaccines. And this article goes on to talk about many of the myths about the vaccines that really have no basis. And I think that this is important to educate people about so that we try to overcome some of the myths about why people are not taking the vaccine. Certainly, if they have reasons that are medical reasons that disqualify them, that's fine. But there are so many reasons that are allegedly given that are not appropriate. And I guess one of the commonest ones was the history of egg allergy, which this article is pointing out is not a reason to avoid influenza vaccine. Any other comments about this article? As most of us have safely taken the influenza vaccine yearly for some time now, and remember, uh, as the time for vaccine comes around, don't forget, if you're over 65, get the extra potent vaccine. Don't get the regular vaccine. Get the extra potent vaccine, which is particularly for people over 65. And that's very important because as you age, your immune system wanes, decreases in its potency, and so you need to get the double portion of the vaccine, and you have to specifically ask for it. John?
Yes, good morning, everyone. I've heard, several times from several different people, and they are forceful with their beliefs that they get the flu from the flu shot. And, I try to tell them there's no basis in reality for that. And I'm not I'm not as sure about the egg allergies. I've never known or heard of any of my associates or friends who have a egg allergy that the flu shot could affect. But there's a lot, and with the, like you said, the current administration, um, and I just heard yesterday that Florida is about to eliminate all recommendations for all vaccines. So there's so much negative.
No, they're eliminating mandatory.
Mandatory. Right. That's what I meant to say. There's so much negativity going out, and people are afraid by that, and they won't get vaccines. But I hope people like us who get the good information can spread the positive word to our friends and families that these are methods that can save our lives. Thanks.
Yes, an ounce of prevention is worth a pound of cure. And so it's interesting that the people who resigned from the CDC resigned because they felt that it was harmful what the new administration was doing with the vaccine issue. Because it's an important issue because the whole health system is based upon treating diseases, but moving forward, we should be more interested in preventing diseases. And that's what vaccines do, and we should therefore use them to the utmost. Thank you for sharing, Mr. Buchanan. Any other comments before we go to the next article?
Dr. Perez had her hand up.
Okay. Go ahead, Dr. Perez. I can't see hands anymore for some reason.
I wanted to say we shouldn't just spread, we should scream. We should scream. Our public health service across the country is being dismantled. And we have a saying, when white America gets a cold, we get pneumonia.
Well, I couldn't agree.
We are at, I just cannot believe, we as disciples have got to scream this.
Words of wisdom. Words of wisdom. Yeah. Okay. Thank you for sharing. As we try to continue to scream. I see where the Supreme Court, I'm sorry, one of the judges overcame the case of Trump against Harvard. So it's going to be interesting to see how many of these things work out. So time will tell. All that glitters is not gold. And We've only just begun, so
Thank you.
we shall see what we shall see. But
Doc-
keeping quiet is not something that we can afford to do.
Yes. Dr. Callender, Jan is one of my wellness center's friends. She has a question.
Yes, Dr. Collier, I wanted to ask you, the question is, I have a good, great doctor, but I had, recently I had, been in the hospital and I do have, COPD, which goes, CO,
COPD?
yes, and also I have, asthma and problems with my breathing. And I had my lung doctor, Dr. Craig, and she was telling me at the time that not to take that new shot that they had. And I'm going to take it because I always took my shots. So my question to you is, do you think it's a certain amount of time that I should wait before I get that shot?
Well, it depends which shot you're talking about. For the flu shot, uh, I think that it's a good idea to get that shot in October.
And
Uh, Only because if you're over 65, the immune system wanes and the shot will last for a good 6 months. Uh,
okay,
so that I tend not to take it in August, not even in September. I take it early October. Uh,
okay,
but, but
72.
but you're wise in understanding that, especially if you got COPD and
Yeah,
asthma,
yeah.
that an ounce of prevention is worth a pound of cure, and getting those vaccines before the fall season comes is very important to your health.
Okay, I'm 72 years old and thank you, thank you.
Okay, thank you for your question. Okay. Uh, did you identify how many people are in your group yet?
Right now, some of them left to go to the exercise class. So right now it's about 10.
Oh, okay. All right. Thank you. Okay, any questions they have, please, yeah, break through and let us hear them.
Okay, thank
All right.
you.
Okay, let's go to the next article then, John Buchanan, unless there are other questions. This is an article that is talking about multiple cancer early detection screening that we do. We have many blood tests that we now use to try to identify early cancer. And this is done to decrease cancer mortality and morbidity. We haven't done a whole lot of studies to prove that these blood tests are doing what we want them to do, but it does appear that certainly we now have tests that will diagnose this blood tests that will diagnose cancer earlier than we thought before. But so far, we haven't done the studies that would prove that these cancer tests, for example, this Galleri test that looks for circulating tumor DNA, will make a difference. So that they're recommending that if you're over 50, that these blood tests may be a benefit. However, we haven't done enough screening and enough analysis of the screening to prove that this is going to be a benefit. So this is the newest advance in cancer, in which you don't necessarily wait for the cancer to develop. You look for the tumor cells in the blood. And that this is something that isn't available to everyone, but where it is available, it can be used. You had a question? Any other questions about this? Because this is a relatively new subject, because everyone is not associated with these Galleri blood tests that look for tumor DNA first. And then once they find that, then they look for the actual tumor.
I had
So
a
this is
question, Dr.
relatively new.
Callender. If they find tumor DNA, how do they know what kind of cancer it is?
They don't. Then they go back and try to identify where it's coming from. And because it only finds that you have tumor DNA. It doesn't localize it. Subsequent tests would have to be done to localize, and that's one of the weaknesses of the new tests. And they are, I guess, particularly valuable in people who are immunosuppressed, who are overweight, and people who smoke and things like that. But we've got a long way to go before we can authenticate that these blood tests uh, will help us detect more cancers early. But this is the intent of the new tests. And I think John Buchanan's question pretty much heralds what is problematic about it. It doesn't tell you exactly where it is. It just tells you that you've got a cancer somewhere.
Dr. Callender, is this test being done now on a regular basis, or
Well,
is
it's a test that is done at some cancer centers, not all
okay?
cancer centers.
Okay.
Primarily, National Cancer Institute is recommending this study, but it's still in the investigational stage. Any other questions?
Yes, Dr. Callen, Janice has another question.
Okay, Miss Nancy Janice again. I wanted to ask the question, are this blood tests that will pick up cancer, are they offered now in doctor's offices? Did I ask?
No, they have not. So far, there's done in a number of, as a consequence of the National Cancer Institute, they're done in many cancer centers, but many physicians' offices may not have this these tests. And you can see here they have a list price that is prohibitive, $949 to uh, flag a possibility up to 50 different cancers. So I'm not recommending it. I'm just saying it's available. Uh,
Okay.
there's so many questions associated with it. Once you get a positive test, that it remains to be proven that this is something that is helpful. But there is the expectation down the road as we learn more that if we find these tests that are positive for tumor DNA, that we will be able to localize and find what is the source of the cancer. But the expectation is that if we find it early, that this may be result in us being able to treat it earlier and cure it earlier. That's the idea. But many physicians' offices will not have it, but many cancer centers may.
Okay, thank you. Thank you.
Okay. And that list price of $949 is somewhat prohibitive, although some Medicare beneficiaries will cover it. So on to the next article.
Dr. Callender,
Yes,
how does that or does it relate to the BRCA test?
to the what?
BRCA, is it BRCA test? Doesn't that identify
No,
cancer?
that's a specific test
Okay.
for breast cancer.
Okay.
Yeah, which is the other test, the Galleri test, is investigational. The BRCA test is well known, and we identify specific cancer aspects. So that's very specific. The BRCA is very specific, whereas Galleri is probing. Yeah, whereas BRCA, once you find out whether it's estrogen dependent or independent,
Mhm.
uh, then that tells you how to treat the cancer. So it's a specific test that is very different from this probing test. This test is BRCA is very specific and is able to identify whether or not you need chemotherapy or radiation
Okay.
for treatment of your breast cancer. So it's uh, BRCA is more definitive,
Okay.
whereas Galleri is investigational.
All right. Thank you.
Dr. Callender, I had a question about a Z spike. I discussed it with the medical team over at Georgetown, and they were saying that you might find a Z spike in a very small indication of cancer in the bone. And I
I
want
didn't
to know,
understand the word you used.
Z as in zebra, spike.
Oh, I'm not familiar with a Z spike, so
Okay.
I can't to help you with that.
Um,
Any other questions? If not, we'll go on to deaths from prostate cancer.
I had a question.
Yes.
As we go forward, and the importance of how it's important for our community to be involved as we gather data, be it clinical trials, uh, being those things that will inform AI, which will drive how many medical decisions and procedures are done, are paid for. So, with these probing studies that are prohibitively expensive, which disproportionately impacts people of color, will this information move forward without having an adequate population base that looks like me?
Well, the problem is that with the dissolution of many of the groups that look at this data, it's going to be harder to identify what is important for us to have and what is important for us not to have, because many of the research studies are being unfunded, defunded, and unfunded. And so the impact upon communities of color is going to be, can possibly be great. If this new administration continues to dissolve research and funding for research, then that will have a negative impact upon all communities, but particularly communities of color. Does that answer your question, or does that just make it more muddy?
No, it answers it, and it pushes us to make sure that um, our research and development moving forward isn't associated solely with profit. As the federal government, which has been a major funder of this type of early research, which isn't product based, has severely been cut by this administration.
Yeah, and I'm hopeful that as the court deal with the imposition of the new administration on research and research funding, that something will be done to push them back, because they're actually destroying the ability of the United States to be a leader in research and other technologies. At least that's my perspective of it. And so we have to keep our eyes tuned to what's going on and let our spokespeople communicate with Congress and let them know that they need to be more active in terms of protecting us. Because right now, the Republican administration is going along without being stopped. And that's the role of the Congress of the United States. But the Congress is not doing its job. And many feel that's because the House and the Senate are both run by Republicans. And so we need to change that as soon as possible. Otherwise, this destructive element of will continue to proceed unaltered. Any other comments or questions? Because these are important issues.
Yes, I have had in the back of my mind for a long time since Barack came on board and in control Ebola. Remember how bad Ebola was to the point where if you got it within hours, you would be dead. And if something like that, which is possible, could evolve here in the United States or really anywhere in the world without a program, without proper procedure for dealing with it, which we did have under the Obama administration, it's very possible that pandemic isn't strong enough a word to handle something like Ebola on a worldwide scale. Very afraid of that.
Thank you for sharing. Thank you for sharing. So we have an immense job ahead of us to protect our future. So Dr. Perez's request for us to scream out is very important, and for us to communicate with our Congress people is something that we are obliged to do. This article is an article demonstrating that prostate cancer, if you have a low risk prostate cancer, that means not aggressive prostate cancer, the risk from dying from your prostate cancer is very low. On the other hand, if you have an aggressive prostate cancer, the risk of dying from it is very high. So management of prostate cancer, which is a disease that affects only men, is different if you have metastatic prostate cancer and if you have a non-metastatic prostate cancer. The point is that yes, prostate cancer, which is very common in Black men, can be if it's non-metastatic and it's not aggressive, can be watched and handled and treated very easily. But if it's aggressive, it has to be treated very aggressively. Otherwise, it will kill as well. And since this is a disease that particularly involves Black men, it is imperative that we resist the
I can't hear you, Dr. Callender.
Can anybody else not hear me?
You're back now.
So it becomes imperative that Black men get PSAs. There's the there's the opinion among the white population that black men don't need to get PSAs, but that's not the case. We have more prostate cancer than whites, and we need to get PSAs. And if they're elevated, we need to be treated, particularly if it's aggressive cancer. So this is an issue in which there's a difference between the disease incidence in the black population and the white population, and we have to be very careful that we do not stop getting PSAs in our black men, because that gives you an earlier diagnosis of prostate cancer, which may be treatable, and when it's not aggressive and when it's not metastatic. And this is a cause of concern because there have been many publications that said that PSA test is not necessary for blacks over a certain age, which is not the case for black men. Any comments or questions about that? Mr. Buchanan?
Yes,
I have a comment.
Yes, go ahead.
Zoom. It's reading at the bottom of my device saying this meeting is being recorded. It's also being transcribed for AI companion.
So what is your question or comment?
That was just a comment.
Oh, okay. All right.
Yes,
Right.
Miss. We have John Tatum. He handles the technology as well as John Buchanan. So they're doing that.
Right.
Okay.
And if you want to get a copy of it, if you want to get a copy of it, you can get a copy.
Oh, okay.
Thank you, Miss Sue.
Yes.
So
You're interested. John, you want to respond to that?
my question though was, with the PSA, only tells you the presence. It doesn't tell you the kind of cancer it is.
No, it just tells you you have prostate cancer. Other tests will identify where it is, and the biopsy would tell you whether it's aggressive or not.
Okay.
And then other tests will find out whether you have metastases or not.
Okay, thank you.
But the PSA is just a screening test that lets you know that if your PSA is well above 4, that you have prostatic cancer, and you need to have further tests to identify the state of the cancer and what kind of treatment is necessary.
Elizabeth, offline, John Buchanan can get in touch with the suit lady and send her a copy of the video. We can do that offline.
Right, but as you know, every after every program, the the recordings are available. So as you said, getting in touch with John Buchanan would facilitate that.
Yeah, for either video, audio, whatever.
All we need is your email address.
And we can do that all offline.
Yeah.
Yeah.
Just forward your email address, and we'll add you to the list, and you can get the recordings.
Miss Sue, I'll take care of that with Miss Davis.
Thank
Okay.
you.
Very good.
Thank you.
Very
Any
good.
other questions?
It's no problem. I'm just being nosy.
Oh, we
No,
appreciate it. So everybody would know that it's available. Right. Okay. So we'll go to the next article then. If this is an article that is important to recognize that alcohol has its merits and cardiovascular, but it does increase the risk for pancreatic cancer. And this article talks about, and that's the essence of this article, is to point out that yes, it may have its merits for one drink a day for cardiovascular aspects, but that it does increase the incidence of cancer. And so it answers that question. Some people still feel that no alcohol is the best alcohol, but in terms of cancer, there is an increased risk with cancer, pancreatic cancer, and other cancers. Any comments or questions? If not, we'll go to the next article.
I had a quick question. Why do you think it is more deleterious to females as opposed to males?
I have no idea. I I have no idea. That's an interesting finding that they have consistently found that to be the case. But I really don't understand why it is different for women and men. But the data consistently identifies that. Now, those who are cancer survivors would appreciate this article because it talks about the fact that we have chemotherapeutic agents for cancer that may be successful, but there's a good side and there's a bad side. There's side effects of cancer treatment that sometimes are absent and sometimes present. But when they're present, they require careful monitoring. And this particular case emphasizes that when you have treatment for cancer, that sometimes the treatment may be as dangerous as the disease itself. Sometimes it's beneficial and curative, but in sometimes it causes side effects that increase morbidity and mortality. And this is an article that just tries to balance the equation so that you don't think that therapy is one-sided, curative only, but it is actually requires very expert handling, just like with transplantation. You have to have a transplant team that knows what they're doing to deal with the good and the bad and the ugly of cancer as well as that of end-stage renal disease. So that's in essence what this article is about, to understand that when you take treatment for cancer, that you have to be monitored and when you have side effects that you have to have them treated aggressively and carefully.
Doctor,
Yes.
I had a question, Janice again. My question to you is, I have cancer in my family on my dad's side, my mother's side too. But I wanted your opinion on this. I've asked it before. It's with them having the chemotherapy, some of them have radiation, and just like you were saying, all these side effects and all this stuff, where some of our people is choosing not to even do the radiation or the chemotherapy. Do you think they could ever come up with something that wasn't that people feared so much that some of them have even gone to be with the Lord because they did not seek treatment, that because they did not want to go through that? Do you think maybe one day, or are they having any studies? You know, we don't often hear in our community, in the Black community. Just coming from you, I would like to know your opinion.
Yeah, there are many studies that now are, first place, it's very clear that you have the option of saying yes or no to the radiotherapy or chemotherapy. I think what is important is I have a niece who just had a diagnosis of cancer. And one of the most important things is to have the doctor or the team of doctors to explain very carefully the risk of the radiation, the ability of the radiation to prevent the cancer, the ability of the radiation to treat the cancer, the ability of the chemotherapeutic agent to effectively treat the cancer, the possibility of side effects, and then once they give you a clear understanding of the pros and cons of the therapy, then I think it's up to the person to make the decision. Right now, many of the therapies that we have side effects that can be frightening, but sometimes the cost benefit ratio is such that it's worth it. But it's something. Your question is an excellent one because I think the best answer is when you have a team that actually explains carefully to you the good side of the matter in terms of what the radiation can do, what the chemotherapy can do, and of course, the best thing of all is to get it diagnosed early, so that you can require the least treatment that's possible. I hope that goes away towards answering your question, Janice.
It does, and I appreciate it. Thank you very much.
And I have a question on Zoom. I had breast cancer, and if almost 22 years survivor, and I had both chemo and radiation. But the chemo left my organs weak, my heart, my kidneys, and a few other things. So, but the doctor said I'm a miracle because I have survived 22 years.
That's wonderful. That's wonderful.
Yeah, but I caught it at the early stage because I only missed my mammogram 1 year. And when I went in to get my mammogram, that's when they found that it was the size of an eraser.
Okay, thank you for sharing. Thank you very much for sharing. Any other questions or comments?
Yeah, I had a comment about John Buchanan's question about alcohol in females. Females are more impacted by alcohol than males due to biological differences, including a higher percentage of body fat, which retains alcohol, and a lower percentage of body water, which dilutes alcohol, resulting in higher blood alcohol concentrations. Women also have lower levels of the enzyme alcohol dehydrogenase, ADH, which breaks down alcohol in the stomach and liver, allowing alcohol to stay in the system longer and have a greater effect on the brain and other organs.
Thank you for sharing. Okay. Any other comments or questions? Okay, let's go to the next.
One more question.
Yes,
About the PSA test,
yes.
I have a large prostate. Okay, now they're talking about giving me some kind of dye, something in my leg or something to shrink it. I'm wondering, I'm with Kaiser. I'm wondering if how long will it last if I get it? And they also said that by my age, I'm 76, that if I did have developed prostate cancer, that it's so late in the late stages that it wouldn't matter.
What is your question?
My question is, how long will if I get the PSA test and get the thing in my leg or whatever, how they do it for my prostate, enlarged prostate, how long will that last?
Well, if you have an enlarged prostate that is not cancer, then the PSA would be normal. And if it's just then the medication that would shrink the prostate is likely to be effective, and then you just follow the PSA, and as long as the PSA stays normal, then it means you don't have prostate cancer. So they do have medication. An enlarged prostate is very common in men over 65, and medication to reduce the size of the prostate so that you don't have to urinate all the time, and is usually very effective, and so that I would say that the medication takes effect in within weeks. Within weeks, if you, as long as you're sure you don't have cancer, it's just an enlarged prostate, and it's something that men over 65 invariably get an enlarged prostate or prostate cancer. Does that answer your question? If not, uh, help me to do a better job in answering your question.
He said, yes, it does. He
Okay.
just a little ways back, but he said, yes, it does. And he said, thank you, Dr. Callender.
Okay. All right. Okay. Any other comments or questions? If not, we'll move on to the next article. This is an interesting article that identifies that there's some cancer drugs that in animals now, keep this in mind now, in animals that actually increases the cognition of the brain. But this is in mice work. And it's hopeful that maybe some of these same cancer drugs could be used in humans to increase the cognition of people with Alzheimer's. But keep in mind that this is to let you know that research is being done, even though we don't have the cure and treatment for Alzheimer's yet. We have much research that's being done to try to find out how we will eventually overcome this disease. And this is one of the research efforts in mice that demonstrated that some of the cancer drugs, two of them in particular, were capable of improving cognition in patients with Alzheimer's. Any comments or questions? It identifies the drugs, but remember, this is mouse work, not human work.
Dr. Callender, how can they tell if a mouse has Alzheimer's?
Oh, they have ways of testing the ability of the mouse to solve questions and answer questions. And that's how they do it. They give them tests and they see how they respond to the tests after the medication and with the medication, then without the medication.
Okay, I still, since they cannot speak, I
Oh,
took
yeah, they can take tests and they can demonstrate their ability to take tests. And they put them through tests just like they put humans through brain tests. They ask them questions. Well, they do the same thing with mice.
Oh, I thought they just ran through a maze. But
Well, they have all kinds of ways of testing mice. Maze is one of them.
oh, okay, thank you.
Some things that work in mice work in men. Some things don't. But many people believe that the mouse is the model that is very helpful in terms of telling what will work in men. Any other comments or questions? If not, we'll go to the next article.
Well, something else that's a possibility. With Alzheimer's, there's a development of amyloid plaques in the brain, and they can test that with mice too. If mice have Alzheimer's, they can detect amyloid plaques that they can pick up through MRIs.
Thank you for sharing. This is an article that talks about vitamin A, and that we know that the right amount of vitamins is good for you, but too much or too little is not good. And this studies that this is true for vitamin A as well. We know it's true for vitamin D, but it's true for vitamin A as well.
Listen, doctor. Question.
Yes.
Okay. What's the amyloid plaque of the brain? What's that?
What's the question? Repeat the question.
Now repeat it.
The question was, what is an amyloid plaque? It's a
Oh, okay.
protein that builds up in the brain that entangles the brain, kills neurons, which are brain cells, that causes a lot of the symptoms of Alzheimer's.
Thank you for sharing,
Thank
Darryl.
you. Thank you.
Okay, so vitamin A is good for you, but unless you have a low vitamin A or a high vitamin A, getting sweet potatoes and eggs will give you enough vitamin A. But we know that a balance of vitamins is critical. Too much or too little is not good. And this article just points it out. We talk much about vitamin D and we often do not talk much about vitamin A. So this is one of the articles that points out that. Question? Yes?
So I'll take multiple vitamins once
Good,
a day.
good,
Yeah, that's all I take is the multivitamins.
good.
And
But it's also good to be sure you get your vitamin D level checked because
yeah,
vitamin vitamin D is often found to be low in people of color. So it's a good idea to from time to time to get your vitamin B and vitamin D levels checked to be sure that you're not low.
yeah. And I was asking the doctor, what foods should I be eating to help? And he told me anything I want in moderation.
He's right, and as long as you're not low, then yeah, your supplements and what you want and in moderation. Of course, we recognize that plant-based diet is the most healthy. But anyway, and this shows this. You see this front that talks about the things that are good for you: carrots, pumpkins, sweet potatoes, spinach, tuna, and beef liver, and it goes on. Yeah.
Question.
Hello, doctor. Hello, Dr.
Yes.
Janice. My question to you is, I have some health concerns, but I'm really stay on top of my on my health, going to my doctors and doing what I need to do. But one thing I had issues with is my doctor was Dr. Barry Smith. He was a graduate of Howard, and now I go to Dr. Daniels. But each one of my doctors do not was not prescribing vitamins to me. They said I really there's vitamins and I didn't need them. I had my blood tests and everything. But I do know Elizabeth educates us so well at our wellness center and the things that she does. But I know I'm have to get on top of that. What's your opinion about you talking about vitamin D? I know it's all kinds of vitamins and stuff, but is there a reason why some, I know you can't speak for them, but do not recommend taking vitamins, any kind of vitamins? I do it, I will do it anyway, but I just want your opinion on.
Yeah, I think as long my doctor, for example, will get vitamin D levels and vitamin B levels to identify whether you have a deficiency. If you have a deficiency, then taking vitamins is imperative. In other words, you must take them. On the other hand, if your uh, vitamin D level is normal, if your vitamin B levels are normal, then you don't have to take them. Although my doctor does recommend multivitamins. Uh, if your doctor doesn't, it's okay as long as you're not deficient in any vitamin level. So the answer is to get your vitamin B and vitamin D levels checked by your doctor. And if your levels are normal, then taking vitamin supplements will not hurt you.
Oh, okay, I just wondered because it just says, no, I would let you know, I've been with them a long time and I was just wondering because I just felt everybody's been taking these vitamins and I know, I was just wanted your opinion. Thank you though, thank you.
Yeah, there have been many tests of vitamin supplements, and most of them say that they're not going to hurt you But it's if you are vitamin deficient, then it's mandatory that you take uh, vitamin D and vitamin B if the blood tests show that you're low. If they're normal, then vitamin supplementation is okay, but it's not mandatory.
Okay. Thank you. Thank you again.
Okay,
We have
appreciate the question.
A question about vitamin D. I I take vitamin D every day, right? And they had told me at the doctor to start taking them. That was about a year ago. So I've been taking them ever since. You know, I go to the health store and get them and take them every day. I take my medicine. So is that taking too much?
As far as I'm concerned, if your vitamin D level is normal, whether you take a supplement or not is optional. It's optional.
All right.
Okay.
Okay.
Not optional if your vitamin D level is low. But if
Yeah.
your vitamin D level is normal, then it's optional.
Okay.
Thank you for your questions. Next article, please. This is a article about blood pressure, and the reason we talk a lot about blood pressure is because heart disease is still the #1 killer in the United States and in the world. And one of the reasons is because we have so much hypertension, high blood pressure. And one of the reasons we have so much high blood pressure is that people are not taking their blood pressure medications. Uh, we know how to treat hypertension, but if you don't take your blood pressure medicines as the doctor has ordered, then it's of little value. So, and in order to do this, you have to be able to take your blood pressure and you have to take it and record it and monitor it. So having your blood pressure taken once or twice a day and appreciating the fact that the blood pressure taken at home is the one that is most important, that the blood pressure in the doctor's office is important as well, but the one that is most reliable is the one that you take at home. And for that reason, everyone should have a blood pressure monitor that you take at home and also take in the doctor's office. And it's important how you take it, where you take it, and what you're doing when you have the blood pressure taken. So this article is emphasizing that getting your blood pressure taken, monitoring your blood pressure, taking it home, and under what conditions you're taking it, under conditions where you're quiet and you're not doing anything else, it becomes imperative. And I think this is one of the most important uh, things to do as a person who wants to live a long life, is to be sure that your blood pressure is normal. Nowadays, there's an article we'll get to that talks about the new level of blood pressure, saying that the blood pressure should not exceed 130 and should not, if it's over 130 over 80, then it requires appropriate diet, exercise, and if that doesn't get it below 130 over 80, then you need to be on medications, and the medication that you take, you must take. And if your blood pressure normalizes, you still take your blood pressure, because some people, after they normalize the blood pressure, sometimes the blood pressure then goes back up, and hypertension causes heart disease, kidney disease, strokes, and heart attacks. So that it's important for us to get our blood pressure taken at home and in the doctor's office. Any comments or questions about,
Yes,
do all of you have blood
I
pressure
have a comment.
apparatuses? Yes.
I have a comment. I have well, when I left the hospital after I had an aneurysm in '07, they gave me a blood pressure cup, and I take my pressure twice a day. In the morning when I get up, and at night before I go to bed. And I keep a recording of it. So when I go to the doctor, I carry it and they can see But it's been good so far.
Wonderful. That's good. What you're doing is wonderful. And I hope everybody heard what you said because that's what everybody should do.
Yeah.
Thank you for sharing.
John Buchanan here. I also heard that it's recommended if you do have a sphygmomanometer at home to take it with you when you go to the doctor to compare it with the one in the office to check how accurate
Yeah,
your
that's
machine.
also required by the doctor to bring my and then I take it in the office so he makes sure that I'm taking it right.
Thank you for sharing, both of you. Any other comments or questions?
Janice.
Yes, Janice. My question to you, doctor, is I had the one that go on your wrist, and then I have the other one that go on my arm. And I have heard that the one that go on your wrist is not quite accurate as the one is better to take the one that goes on your upper body on your arm. And I had put in to get a new one. I need a bigger one, and I'm a larger size one, so I need a bigger cup. But my insurance would not pay for it at that time. I'm hoping that when I put it in, that they would do that. Otherwise, I will buy it because I was definitely taking mine. But I want to know your opinion about the one on the cuff. Is it accurate or not? Or should I really make sure I get the one that goes on your arm?
You need to get the one that goes on your arm.
I feel okay. Thank you. Okay.
Okay.
And can I ask the question, why isn't it covered? Because we know that the one on your arm is better than the one on your wrist. And so if there is an issue, I will stand up with you as to why you are being denied this by your insurance.
Thank you for sharing, Lucy, because I agree with you. 100%. Yeah.
Yeah, because when I left the hospital, they gave me one.
Well, they cost about between $50 and $100, but it's worth it.
I have a comment.
Yes, John.
My comment is as far as checking your device with the one in the doctor's office. And I think John Buchanan recently brought that question up. I don't think you have to check it but a few times. I don't think, my point is that you don't have to, you do it one or two or three times, you don't have to do that particular device every time you go. You check it about 4 or 5 times and you're fine, then you don't have to take that, every time you go to the doctor, you're taking the same device. I don't think you have to do that.
Well, I think that Sue is doing the right thing. Taking it twice a day, morning and afternoon.
I didn't mean the pressure. I wasn't talking about the pressure. I'm talking about the cuff.
Talking about what?
The cuff, CUFF.
What about the cuff? Yeah.
My comment about the cuff was a couple people talked about taking your device that you have at home and checking it with the doctor's device that he has in the office. My comment was that, yes, do that 2 or 3, 4 times, but my comment was that you don't have to do it for life.
Okay. I see. Yeah. Right. You want to do it just to make sure that it's done right after that.
Right. Exactly. Thank you.
Okay. Thank you for sharing, John. Okay. All right. We'll go to the next article then, if you have more questions. This is an interesting article that says that more heart fat is linked to greater risk of atrial fibrillation, which is a condition in which the heart rate goes above 100, and it is not rhythmical, and it is associated with blood clots. And so for that reason, if you have it, it has to be treated. Now, they've identified that you have more fat. You're more likely to have atrial fibrillation, and therefore the treatment is to decrease the amount of fat, which is easier said than done. But anyway, this is something that has just been identified recently, and so we'll need to have more time. But uh, they are suggesting, and though this is not demonstrated, that if you decrease the amount of fat, that you will decrease the likelihood of atrial fibrillation. So that this may or may not, this is new research, and over time we'll have to see whether our efforts at reducing the fat will reduce the risk for atrial fibrillation, because atrial fibrillation is a condition that needs to be treated and eliminated if possible. Otherwise, you have to be on anticoagulants. Any comments or question about atrial fibrillation, which may be a term that many people are not familiar with, but it's an arrhythmia or rhythm where the normal rhythm of the heart is abnormal. And it is because of this abnormal rhythm, you're more likely to have blood clots. And so one of the treatments is to defibrillate the heart by electrical treatment, or to just put you on anticoagulants. Any comments or questions for those who have about atrial fibrillation?
Yeah, I had atrial fibrillation, and it was treated almost a year ago by what they call cardiac ablation, and it
Right.
was minimally invasive, and so I've been AFib free since that procedure was done.
Right. And so that is the treatment of choice for atrial fibrillation. And if you get that done, you don't have to be on anticoagulants.
I was lucky as well, Darryl, um, because I had it, and I also had to go to the hospital and have it treated. But when I got to the hospital, they said, "Wait a minute, take your gown off. You can go home." And because uh, I don't know if it was a misdiagnosis, but anyway, it resolved on its own. I just put it that way.
Thank you for sharing. Okay.
And one of the benefits of this Zoom session is that Dr. Callender, you had a cardiologist who was on your program, and he recommended the cardiac ablation. And so right after I made an appointment right away with my cardiologist and said, am I a candidate for the ablation? And I was. So, I did that thanks to this program.
Thank you for sharing, Darryl. Let's go to the next article. Now, along those lines, one of the things that I mentioned in a previous program is that one of the things that differentiates the wealthy from the unwealthy is that many of the wealthy have the smartwatches, and the smartwatches can pick up arrhythmias that you wouldn't ordinarily pick up, and can alert you to whether or not you have a heart rhythm problem. And this heart rhythm problem, once you diagnose it, can be treated, and it can be life-saving. So one of the things that I'm bothered by is the fact that smartwatches may cost money, and some of the not so wealthy people may not have them, whereas many of the wealthy people have them. And so if they find out that they have an arrhythmia, they go right to the hospital and treat it, whereas some poor people who don't have a smartwatch may not know they have arrhythmia and can actually die. So anyway, it's food for thought. Any comments or questions about that? If not,
Yes, Dr. Callender, come closer. I have a wellness friend that at the center, she has a question, but she's trying to figure out how to frame it. So say something so he can
I have AFib, and my cardiologist put me on Eliquis,
And he said something to me not too long ago about a procedure, but I don't remember what the procedure was. And he did not recommend it.
Well, you heard most doctors, it depends. Most doctors would recommend an ablation if you are a candidate for it. So your doctor may have, just ask your doctor why you're not a candidate for ablation, and he will tell you why. Because if you're not a candidate for ablation, then you would have to be on anticoagulants therapy.
Called ablation.
Yeah, that's the procedure that Darryl had, which that's the name of it, an ablation in which they treat and eliminate the fibrillation. But
Okay.
if the fibrillation is not eliminated, then you have to be on an anticoagulant.
Okay. Thank you. Thank
You're quite welcome.
This is an article on probiotics demonstrating that the microbiome or the intestinal flora are helpful in treating cardiovascular issues, and that they lower the cholesterol levels. And this also gives you an idea of how yogurt and probiotics, fermented or grain-based foods, will decrease the bacterial content, lactobacillus and other bacterial strains, because they reduce the inflammatory markers and lower the bad cholesterol. And this then is a way in which your heart is treated by probiotics. And this has a list of the natural probiotics that actually are of value. Any comments or questions? Because this is a subject that is not often discussed.
Yeah, my comment, probiotics are very valuable. At the top of each list that you see, it's usually yogurt and cheese, and those are animal based, and they're also dairy probiotics. And very few black people have the enzyme lactase that can break down dairy products. And so the plant based probiotics are much more recommended for black people, such as sauerkraut, uh, fermented beverages as kombucha. In most grocery stores, you can pick up kombucha. That's spelled Kombucha. And also, fruits, bananas, apples, and berries are good as probiotics.
Thank you for sharing, Darryl. Okay, any other comments or questions? Let's go to the next article, which will be our last one. Now, this is a very interesting article because most people who have coronary artery calcification scores of 0 feel that they're okay. And this article says that if you have elevated LDL cholesterol, you still can have non-calcified plaques and future coronary heart disease, even with a 0 coronary artery calcification score. So emphasizing the importance of knowing your cholesterol level, particularly your LDL cholesterol level, which is the bad cholesterol. We talked about the LPA the last time, but the LDL is well known to be the bad cholesterol. And so with or without calcifications, having an elevated cholesterol can give you coronary artery disease. I want to share this because coronary artery calcification scores are now becoming the rave. And if you have a 0, you still have to get your cholesterol levels taken. And you should know, just like you should know your hemoglobin A1C, you should know your cholesterol level also. Any comments or question about this very important article? Do all of you know your cholesterol levels, your LDL cholesterol levels? Do all of you know your hemoglobin A1Cs?
I just got my A1C level this morning, and it's back to well, what I call zero. It was like 95, and that was from when I first came to this hospital when it was 535.
No. Now remember that's not the hemoglobin A1C.
Oh, it's not? Okay.
No. Hemoglobin A1C, the normal is under 6. Right. What you're talking about is the blood sugar, which is not the same as the hemoglobin A1C.
Oh, yeah. Yeah, I think it was 500 or something.
Yeah, right. But that's just the blood sugar level. Right. The
Yeah,
one,
the blood sugar level is what I'm talking about. And now it's down to 95.
right, which is normal. But
Right.
the real,
In
what
5
I'm
days.
saying, you should know what your hemoglobin A1C is, because the hemoglobin A1C tells you what your uh, blood sugar level is all the time. And that's the most important level to know. Because if your hemoglobin A1C is above 6, then you're diabetic. Whereas the blood sugar varies from time to time, whereas the hemoglobin A1C tells you exactly what your blood sugar is most of the time. And so if it's above 6, that means you're a diabetic. If it's below 6, then you are not a diabetic. The blood sugar is a measure of your blood sugar at the time you take the blood test. And it might be 95 now, but it could be 2 or 300 at another time. So it tells you what it is at that specific time, whereas the hemoglobin A1C tells you what it is for the last month. And that's the better test, and that's the test I'm saying that you should know your hemoglobin A1C, and you should know your cholesterol level.
Mhm.
Okay, I think it's the last article, and we're so thrilled to have your group with us today, and all of you who've participated. We're